Our next presenter is going to be via Zoom, and that is Dr. Shalini Nayar. Is currently practicing as both a respirologist and palliative medicine specialist in British Columbia at the Surrey Memorial Hospital site and the BC Cancer Agency. She attended McMaster University for internal medicine training and subsequently completed the respirology fellowship at the University of British Columbia, as well as the palliative medicine training program. Dr. Nair is currently functioning in the capacity of local department head, acute palliative care program for Surrey Acute, and is a clinical assistant professor with UBC Department of Medicine. Her interests, presentations, and publications have focused on the importance of palliative care interventions in both malignant and non-malignant disease. So let's welcome Dr. Nayar.
Thank you very much. And I hope that you all can see me well and hear me well. I'm just going to share my screen with you guys for my presentation, and I appreciate being asked to speak. I'm sorry I'm not there in person. It's one of my favorite places to be usually, but I couldn't do it with the clinical travel time. So hopefully this goes okay. So what I'm going to talk about today is palliative care in the context of interstitial lung disease, really. You know, I called it pulmonary fibrosis, but it's kind of extractable to the majority of lung diseases that are based on scarring. It's not really, it's kind of a grim topic, I know, but I hope to make it not. I hope to just introduce what we're talking about, the type of language we use, and what we actually mean when we're talking about palliative care. So we're going to define it today, right? And then we're going to talk a little bit about how it can be beneficial to the group. And we'll try to understand the scope. Where can we access palliative care? When would we access palliative care? And finally, what treatments and benefits does our province have that could be helpful to each individual case? So the WHO does a good definition of palliative care. And what I really want to focus on is the improvement in quality of life for patients and families. Like that is 100% of the point. That is what we are doing. We aim to prevent and relieve suffering, and there are many, many different types of suffering and many, many different levels of suffering. But the whole thing is broadly explained because it's kind of a catch-all for any sort of suffering. Part of the importance and relevance to this audience is that early identification leads to the best outcome, the best integration, and the least amount of suffering long-term, and that's been studied in multiple ways. Other symptoms like physical, psychosocial, and spiritual issues should also be addressed. So it's holistic care. Previously, when we think about palliative care, I think most people had thought about the separate disease modifying approach from a palliative approach, like one ends and the other stops. Then there's symptom control and then grief, and those are all sort of siloed. It's not really what we're looking at very much anymore. What we're looking at now is an overlap between all of it. At some point in a person's illness, they may require more pain and symptom management to focus on being stabilized. And at some point, they may require less. And I think that's okay. I think we just need to be flexible and we need to be able to recognize it. We also need to recognize that survivorship and bereavement are a spectrum and encompassed in the palliative care model. Lots of studies have been done on patients who have cancer, right? And in those studies, you know, what's really been beneficial is a shared care approach. So now from that perspective, we have integrated clinics, right? Like the palliative care or pain and symptom physician will follow along the radiation doctor, the oncologist, even when they're receiving active aggressive care. And in a lot of ways, it helps them receive better active and aggressive care because they tolerate their treatments better. So it's a well-established system in patients with cancer. It's kind of less established in patients with non-cancer illnesses. That all of the research coming up and all of the work we've been doing is to try to integrate it and establish it in a very set way with good recognition in people that have long-term illnesses with lots of suffering and symptoms who are not cancer patients. So the question becomes, and the question I'm asked a lot is, are all lung diseases, do they all have a palliative trajectory? And I don't know, right? Some lung diseases, probably not. Many lung diseases, probably yes. And remember that lung disease is kind of a slow burn. So we pick up other age-related illnesses along the way. So it may not even lead someone to deteriorate before another age-related illness occurs that would have happened anyway. So what we can do, though, is look at what people with lung disease feel and look at their health-related quality of life. And what we find is that people with very advanced stages, a lot of them complain that their quality of life isn't great because they have shortness of breath, because they have pain that isn't addressed, and because they have superimposed depression and anxiety that isn't treated, right? And if we view, lung cancer or malignant diseases as amongst the hardest for patients to get through, we find that quality of life in many qualitative studies was even lower than patients that had non-small cell lung cancer. So recognizing that, and not everyone will feel that way, but even if it's a subset that feels that way, we should address it. Patients with lung disease are vulnerable to being at the mercy of their medical professionals. You go by the information we give you. So if we're giving you all of the best information, all of the most aggressive things we can do, we have to be giving you information on how we can help you with suffering as well. Most treatments for many lung diseases do not actually cure the underlying disease, meaning at some point, any person may be at risk of suffering. Looking at qualitative data, which is interviews with actual patients who have pulmonary fibrosis in the United Kingdom, as well as their caregivers from 2 specialist areas, patients had a lot of concerns in the last year of life, and one of them was frustration, anger at loss of independence, and some of you may feel that way. Another is uncontrolled breathlessness, and some of you may fear that happening. Uncontrolled insomnia, which I found, interesting, which I have integrated into my practice, which I ask about. It's a thing, and which should be treated. Uncontrolled cough, and some of you may already be experiencing that. And then the issues with tensions within any family or any relationships, which are all unique and different with people's relationships. The caregiver concerns also felt familial strains. And interestingly, they also felt there was a lack of education regarding trajectory. Like, hey, if you knew that my loved one may be getting sicker, would have been nice to know. Please tell me when things are changing. I think we're learning more as a healthcare profession that people want to know those things. We don't need to ignore them. We can ask, would you like to know, if we're worried that people won't receive that information. And then, of course, there's care concerns from the healthcare team themselves, from the nurses, from the doctors, from any person in healthcare that's taking care of them. And that is a lack of confidence in managing symptoms, right? And that's why people like me try to come in, and other palliative care professionals or other people integrate palliative care principles into their practice to avoid that and gain confidence in managing symptoms. We also underestimate the psychological needs of patients. And by saying this out loud, by recognizing that is how we get better, right? And start to recognize their needs. These are the main trajectories of how people's physical capacity declines over time. The one that I am looking at is the middle one, which is called the organ system failure trajectory. It's been extrapolated for lung disease from heart failure. The other 2, the top one is cancer, the bottom one is physical frailty like dementia. The middle one is very, very extractable for pulmonary fibrosis. And the reason for that is you can see it's characterized by a series of exacerbations and remissions. Get sick, get better, get sick, get better, get sick, get better. But what I would take from this graph is the understanding that that's happening, right? But when that's happening, we don't quite get all the way back up to our baseline. It's a slow and steady decline. And the distance between those plateaus, like, nobody knows how long they're going to be. We think we can guesstimate in some ways, but really people can stabilize for a very, very long time or not. And that's an individually tailored response. That's how people differ. when they respond to their illness. So to blow that up for you, because it's an unpredictable disease trajectory, because it's a series of exacerbations and remissions, which is really, really difficult to tell the difference between time, the earlier you can integrate advanced care planning and conversations about what to do if you were to get sicker, they're important, right? Because we don't know. We don't know completely. And that's true for all of us, with or without illness anyway. There may be some dramatic exacerbations where people end up in hospital, even the intensive care unit. And sometimes when we recover from that, we think, okay, well, I did it once, I can do it again, right? That is a possibility, but it forces you to think a little bit about it. And some people are very surprised by how quickly an illness can escalate to needing the intensive care unit, you know? And I think it's not fair for that to be a surprise all the time. Communication challenge is mainly for this reason, which is we don't have the best way to offer prognostication for how sick somebody becomes. But intuition and functional capacity, how much a person can do, is the way we go, right? So we have to be flexible with it. So when we put together all of the studies looking at what exactly are we dealing with, what exactly are we needing to improve from a pain and symptom management perspective, we see big themes, right? And these may resonate with you. One of them is inadequate supports in advanced disease. How do you get people to help you in your home? What are you expected to tap into? How do we treat intense breathlessness in the last year of life? And how do we deal with a significant lack of social interaction, whether that's because somebody has problems with mood or whether that's because they don't really have a lot of people around them? Burden of symptoms includes increasing breathlessness, cough, fatigue, depression, anxiety, chest pain. So you can sort of break apart those little symptoms into more. But what we know is when we actually address them, right? So if you look at the bottom of this slide, the same study, the same population of patients with pulmonary fibrosis, you'll see that some had painkillers, some had benzodiazepines or tranquilizers, some had access to palliative care specialists. But if you look at the trend of all of those, any person that had any intervention did better, period. And that's just by addressing the big themes that were on that previous slide. So then who would benefit from having a palliative approach? How do you know? How do your loved ones know? Sometimes patients choose from themselves and they say, this is what I want. I want to talk about it. I want to have supportive care. I want to focus on my quality right now in my disease trajectory. And that is without sacrificing any other care, okay? The surprise question, if a medical professional or if you would say, oh, well, would I be surprised if I was sicker over the next 6 months? Not really, the way things are going. That might be a time to talk about it. You can go by sentinel events like that exacerbation and remissions graph. Okay, this is my third admission to the intensive care unit. We need to talk about it because I may not do so well next time. And other clinical indicators that are more disease specific. General clinical indicators we can use as healthcare professionals. What we're doing when we're assessing you, saying you have clinical indicators, is looking at if you have other things that make you more sick or make you more frail, if you've had to go to the hospital multiple times, if there have been multiple complications during that hospital stay that have resulted in a longer hospital stay, if you can do less, and if you need help or if you have dependency on help for the majority of your independent activities. Examples are dressing, bathing, eating, the core things that you need to be doing. And of course, if you have worsening nutritional status, if your appetite is reduced and or you are very, very metabolic because you're breathing very quickly and we can't keep weight on, that may be a sign that you may have lower reserve or the disease is escalating over time. Specifically to pulmonary fibrosis, we're looking at the level of breathlessness. We're looking at changes in your oxygen diffusion on your breathing tests. These are some things that the others have talked about what we're measuring. We look at the need for oxygen or oxygen dependency. We look at the burden of scarring on your CT scan, and we see if you have also high pressures or backwards pressure on your heart contributing to your symptoms. The longitudinal things we monitor are the changes in those things. Are things dropping off quickly, right? Once you identify a person or a person self-identifies as needing added palliative care or wanting to integrate a palliative care approach, there are challenges sometimes to changing the focus of goals of care. And I don't mean what's on paper. I mean what you think about when you're sick. What do you focus on? What's important to you? Goals of care, not a DNR status. That's very different. From what I've learned and from what we can gather from people who self-report, patients are really the ones that are quite aware. They absolutely, usually, right? There are some people that do not want to, and that's within their right, their spiritual right. But most people are kind of aware when they're getting sicker. And they're kind of aware whether or not life support is something that they're willing to do. And that's simply because they've been to the hospital and dealing with the illness for all that time. Most people who see me are absolutely willing to discuss their issues, but we need to be able to get over our reluctance in asking about those issues. And I think we're doing a lot better in healthcare. We have to be able to provide guidance, right? And we have to be accurate in our assessment, but also the caregivers. You guys need to be accurate about their quality of life. I think it's really easy to assume that things are going fine because there've been no disruptions. But we got to ask each other, caregiver to patient, healthcare provider to patient to people, how do you really feel? That's the first step in talking about goals of care, is asking as a group each other, how do we really feel about this? The public or people in your life may feel differently as well. And I don't, every person takes opinion differently. And some people are very good at saying, thank you for your opinion, but no thank you. And some people have very large relationship groups and everybody's got an opinion. So that if there's availability of treatments, and you've heard about many, and including lung transplantation from Dr. Wilson just now, just because it's available doesn't mean that you have to pursue that option ever. And doesn't mean that it's the safest thing for you as an individual. You should always know why. For many, many people, it will be. It will be an excellent option. It will be extremely good as an outcome. But availability, and should it be something you in your own personal disease have, is a thoughtful conversation. And that leads into the notion of doing something. Some people and some relationships and some people in the public view focusing on quality of life is not doing anything to actively prevent problems with your illness. And that's a philosophical way we think. Some people also believe that doing nothing will lead to more discomfort. That's, not always true. It depends on what you're doing, right? There are some religious and cultural beliefs that are obviously to be respected at any time that prevent people from wanting to change their level of intervention, and a general lack of education and understanding about the dying process, how it's initiated, what happens, and where things can happen do pose a challenge as well. The healthcare team, we have our own issues. So a lot of us, coming from an extremely good place, may have unrealistic expectations of success and what we can achieve with current treatments. Not always true, and we are so good at trying to do better. Dealing with illnesses that are just simply difficult to prognosticate, and the best we can do is reevaluate, and be honest. Lack of awareness of options for integration of pain and symptom management when cure or aggressive treatments are no longer possible. Difficulty removing care. This one is hard. It's been a charter right for people in Canada to cease life-sustaining medication or treatments for themselves whenever they'd like. There's sometimes feelings and frustrations at each other, maybe as healthcare professionals, maybe between caregivers and healthcare professionals, regarding what we're calling withdrawal of care, or simply not adding or removing, even in some cases, life-sustaining care. That's not an easy conversation, and it's also a really hard conversation when people have not had like an internal conversation with their family members about it themselves first. So I'm not saying everybody needs to sit around and talk about these things, but you know, they are important at some point. Many of us, we aren't great at breaking bad news, and we don't really like to do it. So you should ask us, right? And then we won't feel bad answering your questions. And then there's the belief from a lot of people that having these conversations takes excessive time. And in my experience, it actually, it doesn't, you know? And I think the more we do, and the more patients challenge us, and the more we answer these questions and learn about it, the not faster, but the more efficient everybody becomes at having these conversations that we normalize. The worst case scenario is a person who sits at home and gets a bad, what we call exacerbation, that lands them in hospital. So unfortunately, they can't now go see their outpatient respirologist, and they are admitted to hospital. They get better in hospital, and then they go home. But because of that exacerbation remission cycle, right, and things are ramping up, like nobody has the conversation of the things that we just talked about. Nobody decides that advanced care planning is something they should speak about. And so sometimes, and I'm not saying it's your onus, but sometimes it's very important for you guys, the empowered, right? People who are living with illness, people who are caring for others with illness, and us healthcare professionals that understand this illness. Sometimes you've got to ask us, like, make sure you understand that it is your right to be able to have these conversations with any healthcare provider that's involved in your care. And then, you know, how do you access palliative care? It's kind of like a black box. And the simple answer is everybody should be able to do some. Primary care physicians, like your GP, if you haven't had experience with palliative care, you'll be pleasantly surprised to find out how much additional training GPs actually do get and can get in palliative care and choose to get in palliative care. It's an excellent system. So having a conversation with your primary care doctor is an absolute amazing way to start, and to talk about mood issues, anxiety, depression, which, you know, cloud your time, right? Become very important. Us as specialists can let GPs know, hey, I saw your patient, I recognized the flat mood. 50% of patients who have a chronic lung illness have a mood disorder, maybe consider treating it. We can also do that, right? They can help you with prognosis, goals of treatment, your code status. They can help you with all of that. When you shift over to specialty palliative care, is when you have complicated illness, like complicated disease, refractory pain or symptoms that are difficult for a primary care practitioner to struggle with alone, or if there are ethical concerns, conflict resolution between any portion of the healthcare team, then obviously specialty palliative care is necessary. The way to access that is by twofold. So one is the BC Palliative Benefits Program, which in this province is excellent. It is ministry funded. It is presumed, I said the last 6 months of life, I think I kind of mean a year, up to a year for lung illness. And I use the would you be surprised question, because we know it's hard to prognosticate. It's dictated by functional status and need. You get access to the community healthcare team, equipment in the home, most of which is heavily subsidized, okay, as well as direct admission to a palliative care unit if symptoms are escalating very quickly. And many drug costs, including dispensing fees, will be covered as well. Any doctor in your life at all, or nurse practitioner, can fill out the benefits and submit them for you. So these are the areas of palliative care that exist. The community, which is the top of that pentagon, which is what we were talking about with the BC palliative benefits. On the right is the palliative care unit, which is an inpatient unit that people may need to stay in for short visits with the intention of leaving once stabilized. Palliative care doctors and nurses can go into long-term care facilities or residential care. Looking at the left bottom, palliative care physicians can assist any acute care team in any hospital with consultation and co-management. And then the very left is hospice. And hospice is a freestanding structure where people go and live when we think they're in the last 3 to 6 months of life and need additional support that is not able to be managed well in the home, also heavily subsidized by the government. So on a medical unit, if you get admitted to hospital and you need a palliative care doctor, you get the consultation service. They will come, they will see you, they will co-manage your care. On a palliative care unit, that difference is that palliative care doctor and the palliative care nurses will co-manage your care as the primary team. Examples are whether patients may need intravenous infusions of medications, as they sometimes need, and that's what I mean by complex. It gets a bit complicated. All levels of care can be accessed on a unit: transfusions, antibiotics, CT scans, whatever is necessary to move a patient forward and help them feel better can be done. And the scope of care at home is the community support team, and they're well supported. So usually there's a clinical nurse specialist, social worker, spiritual care practitioner, and physicians available to support the primary care team. But your primary care team will still support you, like your GP will still be your doctor. In hospice, it's people who need 24-hour care. Nurses, 24 hours a day, doctor on call, people who may need administration or injectional type medications because they aren't swallowing as well. There are no restrictions in a hospice, really. Visiting hours, celebrations, people can do all of those things there. It's meant to be as close to a home-like setting as possible, actually. They don't really look that institutionalized. And then I wanted to include a short note on treatments, just because once you go through this spectrum of what are my symptoms, how do I get there, who do I access, now what are we going to ask you to do, right? And, most of the time we'll use painkillers to help you with the rate of breathing and the sensation of shortness of breath. A lot of that breathing and ventilation that happens when people increase their respiratory rate is inefficient. And so some of the painkillers we use will improve that efficiency. We may recommend antidepressants or anti-anxiety medications. We recommend community supports, sometimes sleep agents, anti-nauseants, bowel medication. You'll be comforted to know that there is very, very high level scientific evidence and studies done actually that show us that the majority of medications that we are using for treatment in your case, or we may recommend for treatment in your case, are very safe. So the key points that I am hoping that everybody is interested to know is that palliative care is honestly applicable as early as you want it to be. And we need to get at symptoms early to make your voice heard. It is widely available, and we're willing to work with you to figure out how to best make it work in your home. Our treatments are to improve quality of life and maintain your function. Not all palliative care is end-of-life care, so we shouldn't always be scared to hear it, but it's included. But all end-of-life care is palliative care. And this is what I was hoping to get across to you guys today. Does anybody have any questions for me?
Phyllis, Shalini has worked with our clinic since she started in practice, and many of you have probably been referred to her at the very beginning of your issues with pulmonary fibrosis of any type. Very rarely do we wait till the end of life, because we find that with Shalini and her group of physicians, they deal with the finite of the drug easing the symptoms and the path along making life more livable and available to you. Any questions for Shalini? No? Okay. Okay, that's great. I'm not surprised, because I think you covered everything in your program, and much appreciated as usual. Thanks, Shalini.
Thank you so much for having me again this year, guys. Have a wonderful rest of the conference.